Welcome. We have discussed the individual paralytic strabismus entities in the sessions on their respective strabismus patterns. And in this session, we will be discussing the common features of these paralytic strabismus entities. Causes of paralytic strabismus include congenital defects in the muscle or its motor nerve, post-viral or post-immunization inflammation of the motor nerve, trauma to the muscle or its motor nerve, microvasculopathic lesions of the motor nerve, and compressive lesions of the motor nerve. Symptoms which a patient with paralytic strabismus may present with include deviation of eyes, diplopia, and compensatory head posture, which may include face turn, head tilt, or chin down position. The diplopia increases in the direction of action of the paralyzed muscle and decreases in the opposite direction. So if there is a right 6 cranial nerve palsy resulting in palsy of the right lateral rectus muscle, the patient will perceive a diplopia which increases on right lateral gaze and decreases on left lateral gaze. On examining a patient with paralytic strabismus, we will find that the deviation is maximum in the field of action of the paratic muscle. So in a patient with right lateral rectus palsy, the deviation between the two eyes will be maximum in the right horizontal gaze. And one characteristic of paralytic strabismus is with lateral gaze in the direction of the palsy, the secondary deviation measured with the paralyzed eye fixating is more than primary deviation measured with the normal eye fixating. So this diagram shows a patient with left lateral rectus palsy, and when the patient is fixating on a target to the left, with the normal eye fixating on the target, the deviation between the two eyes is said to be the primary deviation, and with the paralytic eye fixating on the target, the deviation between the two eyes is said to be the secondary deviation. And in paralytic strabismus, secondary deviation is always found to be more than the primary deviation. In paralytic strabismus, it is often seen that the monocular duction movements are less limited than the binocular version movements. This is unlike restriction, in which the movement limitations in monocular duction and binocular version testings are almost similar. In a long-standing paralytic strabismus, spread of comitance can occur. Spread of comitance refers to decrease in the difference of the deviation between the two eyes in various positions of gaze with the passage of time. The deviation becomes more and more like a comitant strabismus, in which the deviation between the two eyes is similar in all positions of gaze. And spread of comitance is said to occur due to restriction of the ipsilateral antagonist and restriction of the contralateral yoke of the paralyzed muscle. Spread of comitance can occur rapidly following onset of the palsy. Aberrant regeneration can occur following traumatic, compressive, or congenital lesions of a nerve which supplies multiple muscles. So among the cranial nerves we are concerned with in ophthalmology, third cranial nerve and seventh cranial nerve can show aberrant regeneration. To evaluate a patient with paralytic strabismus, we can perform several tests. Most of these tests have been described in the sessions on motor evaluation of a strabismus patient. These include Maddox rod and double Maddox rod tests. Double Maddox rod helping us to detect and measure torsion. Force duction test to detect restriction of the antagonist muscle in case of prolonged paralysis of the paralyzed muscle. Active force generation test to detect weakness of the paralyzed muscle. Haploscopic tests and binocular visual field testing to monitor progress and recovery with and without surgery. Neuroimaging should be done in a patient with paralytic strabismus if the palsy does not resolve with time, if there is deterioration of the palsy with time, or if there is development of ominous neurological signs. Ideally, all paralytic strabismus patients requires neuroimaging. Myasthenia gravis needs to be excluded in any patient presenting with paralytic strabismus because myasthenia gravis may cause palsy of any one or more extraocular muscles. Treatment of paralytic strabismus is difficult because of incomitance, and so surgical correction of deviation in all gaze positions is frequently impossible. That is why non-surgical measures should always be tried first. Non-surgical modalities of treatment of paralytic strabismus includes occlusion, and the normal eye needs to be occluded in children to prevent amblyopia development. In adults, the paralyzed eye needs to be occluded to prevent diplopia. For small deviations, particularly after spread of comitance, prisms can be used to neutralize diplopia in primary position and down gaze, but the power of the prism should be minimum to stimulate fusional amplitudes in an attempt to strengthen the paralyzed muscle. It has been seen that injection of botulinum toxin to the ipsilateral antagonist in the acute stage of the palsy reduces the risk of contracture of the antagonist muscle. Indications of surgical correction of paralytic muscle includes abnormal head position and diplopia in primary position and down gaze, and these two indications are very important to remember. The objectives of surgical correction include ocular alignment in primary gaze and down gaze, the down gaze being the reading position, increasing the diplopia-free binocular visual field, and improving head position. Surgical correction of paralytic strabismus should be done at least 6 months after onset of the palsy to give adequate time to the paralyzed muscle to recover its function spontaneously, and this is very important to remember. And the muscles which normally act in the field of the greatest deviation must be operated on. So if a patient with right superior oblique muscle has right hypertropia, which is greatest in the down and left gaze, the right superior oblique muscle and or the left inferior rectus muscle should be operated on. And because of the variability in deviation in different gaze positions, recess resect nomograms for comitant strabismus correction are less reliable for paralytic strabismus. And so adjustable sutures are more commonly used in the correction of paralytic strabismus. If residual action of the paralyzed muscle is present, dissection of the paralyzed muscle and recession of its antagonist muscle is performed. But if residual action of the paralyzed muscle is not present, transposition of part of remaining normal muscles to the paralyzed muscle is done. Thank you for listening.